Welcome to this education video entitled Assessment and Management of Youth Depression. This session is a component of our Primary Care Behavioral Health Primer Education video series designed especially for pediatric primary care providers. My name is Megan Benoit Ratcliffe. I'm a pediatric psychologist with Children's Healthcare of Atlanta, and I'm delighted to be your presenter for this session. A bit about me: I'm a pediatric psychologist with 9 years of postgraduate experience, working in both inpatient and outpatient settings across a variety of illnesses and conditions. Caring for those in need is, I believe, one of the highest callings. I hope that you'll be able to take away from this series information and ideas that will help you in the important work that you do. A brief disclaimer: this program offers general information and is not specific medical advice. Always consult with a doctor or other healthcare provider if you have any questions or concerns about the care or health of a child. In case of an urgent concern or emergency, call 911 or go to the nearest emergency room right away. For immediate concerns related to a patient suffering from depression or other behavioral health crisis, call the Georgia Crisis and Access Line at 1-800-715-4225. This line is staffed with professional social workers and counselors 24 hours per day, every day, to assist those with urgent and emergency needs. I do not have any financial relationships or other conflicts of interest to disclose. The primary objectives for this presentation are to discuss up-to-date information on youth behavioral health and mental health risk factors, specifically related to youth depression, to identify unique strategies for youth and caregiver assessment of behavioral and mental health issues, and to develop a plan for managing and triaging behavioral health and mental health issues within the parameters of your current practice. This youth depression series is segmented into 4 sessions. The first session provides a depression overview. The second session provides assessment strategies and differential diagnosis. The third session provides information on how to incorporate caregivers in the assessment and treatment of depression. The fourth and final session provides information on how to assess and treat youth presenting with depressive symptoms. Let's begin with an overview of youth depression. The 12-month prevalence data for major depressive episode presented here are from the National Survey on Drug Use and Health. In 2015, an estimated 3 million adolescents aged 12 to 17 in the United States reported at least one major depressive episode in the past year. This number represents 12.5% of the U.S. population aged 12 to 17. There are some notable differences in prevalence based on sex, age, and race. More specifically, females are almost 4 times more likely than males to meet criteria for depression. Youth in later teen years are almost 3 times more likely to meet criteria for depression than those 12 and under. These statistics in and of themselves warrant concern. Even more concerning is the rise in depression over time. High school and college students today are 5 to 8 times as likely to suffer from depressive symptoms as were teenagers 50 to 60 years ago. As we saw on the previous slide, younger youth are less likely to meet full diagnostic criteria for depression. Among prepubertal youth, approximately 1% meet criteria for depression at any given time, compared to 3 to 5% of postpubertal youth. At any given time, 10 to 15% of youth present with some depressive symptoms, not enough to receive a diagnosis, but still potentially impairing. Recognizing symptoms early can be helpful before depression progresses to a more severe stage. Before the age of 18, 20% or 1 in 5 teens will experience depression. It is for this reason that depression is considered the common cold of mental illnesses. Being able to identify and manage depression in everyday practice is thus an essential part of what you do. One important thing to remember is that sadness does not equal depression. Sadness is a normal emotional response to difficult life events. It is transient and not debilitating. Depression, on the other hand, affects multiple domains beyond just emotions. It affects thoughts, perceptions, and behaviors in pervasive and chronic ways. Beyond feeling sad, people often feel overwhelmed, hopeless, and helpless. Depression is not something that anyone can just snap out of, and in more severe cases, it can be fatal. There are multiple risk factors associated with the onset and course of depression. Heritability is thought to account for 40 to 50% of cases. It is likely that some people are predisposed to depression and that certain exposures initiate the onset of the disorder. Beyond experiencing stressful life events such as parental divorce or deployment, other factors may include, but are not limited to, having issues that negatively impact self-esteem, such as obesity, peer problems, long-term bullying, or academic problems, having been the victim or witness of violence, such as physical or sexual abuse, alcohol or drug use and abuse, being gay, lesbian, bisexual, or transgender in an unsupportive environment, having a dysfunctional family and ongoing conflict, and chronic health issues and disabilities. What triggers a depressive episode in one person may not trigger a depressive episode in another. Classifying depression accurately is more complicated than a binary yes/no response to the question, are you depressed? Several essential features are required in combination with other symptoms. The first essential feature is depressed mood or irritability. Teens are more likely than adults to present with irritability. This is an excess of normal teen moodiness or angst, which may come and go depending on who they are with or what they are doing. Anhedonia, or lack of enjoyment of activities previously enjoyed, is another essential feature. For example, teens who avidly played sports at a younger age may decide not to even try out for the team, reporting they just don't like it anymore. The last essential feature is low energy or fatigue, regardless of how much sleep they may get. The other symptoms affect both physiological and cognitive domains. Physiological symptoms may include a change in appetite or sleep. Cognitive symptoms may include feelings of guilt or a sense of worthlessness. Classification of the severity of depressive episodes is as follows. A mild episode would be considered for more than one essential feature plus one or two of the other symptoms. Youth may report more symptoms, but if symptoms are mild in severity and functional impairment, mild classification would be justified. A moderate diagnosis would be given for more than one essential feature, plus 2 to 3 other symptoms. Again, youth may report more symptoms, but if functional impairment is moderate, this classification would be justified. A severe case of depression would be constituted by all 3 essential features, plus more than 3 other symptoms. Teens may present with fewer symptoms, but if they have psychotic symptoms, recent suicide attempt, or they have a specific suicide plan or clear intent, severity would be established. Just as the symptom presentation varies from individual to individual, so can the course of depression. In general, 50 to 75% of depressive episodes are triggered by an exacerbating event occurring within several weeks prior to symptom onset. This means as many as 50% of episodes can appear without warning. 50 to 80% of cases remit within 12 months, but looked at from another angle, that means depression doesn't just go away quickly for up to half of those affected. 30 to 70% of youth will relapse within 5 years. This can be helpful for both youth and parents so that they can be vigilant about catching symptoms early if and when they return. Effective treatment is associated with quicker recovery and lower relapse rates. Therapy, in particular, can provide helpful cognitive and behavioral skills that can be used prophylactically. Despite this, less than 33% of youth seek treatment for depression. The rate of youth suicide has almost tripled since 1960. It is the second leading cause of death among adolescents ages 10 to 18. More youth die from suicide every year than from cancer, heart disease, AIDS, birth defects, stroke, pneumonia, influenza, and chronic lung disease combined. 4 out of 5 youth who attempt suicide give clear warning signs. Despite this, people can feel uneasy talking about it. It's a myth that talking about suicide triggers people to act. Talking about suicide destigmatizes it and allows people to acknowledge their need for help without worrying that they will be seen as crazy. Every year, there are approximately 500,000 youth suicide attempts, with approximately 5,000 completed. This amounts to about 14 youth suicides per day. Suicidal ideation, or thinking about committing suicide, is not as rare as people might think. The National Health and Nutrition Examination Survey is conducted annually among adults and youth. Students in grade 9 through 12 are asked to self-report on various health issues over the previous 12 months. Recent data indicate that 17% of students seriously considered attempting suicide. By gender, almost 1 in 4 girls and 1 in 5 boys. 13.6% of students made a plan about how they would attempt suicide. The most common methods include poisoning, suffocation by hanging, and firearms. 8% of students attempted suicide one or more times in the past year. 2.7% of students made a suicide attempt that required medical attention. Though females are 3 times more likely to attempt suicide, males are 4 times more likely to complete suicide, often because they use more lethal means, such as firearms. For more detailed information on youth depression and suicide, including statistics and family-friendly handouts, please visit some of these quality websites. This concludes our first session, Youth Depression Overview. The next session will focus on assessment strategies and differential diagnoses. We hope that you found this video useful and informative. From Children's Healthcare of Atlanta, we thank you for watching this video.